Okay, so let's talk about some of these pharmacologic targets. So let's start with the alpha-1 agonists. So again, we just talked about this. The alpha-1 agonist will activate the GPCR protein, leading to vasoconstriction from the increased calcium. And that's because of diacylglycerol, protein kinase C, and IP3, right? The thing here, phenylephrine is your classic alpha-1 agonist. And you might be saying, well, I thought that was norepinephrine. Norepinephrine's up there too, but the thing is norepinephrine is non-selective. So norepinephrine has activity at alpha-2 receptors, it has activity at beta-1 receptors, and we'll talk all about this coming up, but phenylephrine is purely alpha-1. So again, vasoconstriction, most of this is going to be at the arterial side, and so you're going to get a very significant, usually very significant increase in your afterload. Okay, in your afterload or your TPR, okay, or your diastolic blood pressure, okay. Now, non-dihydropyridine calcium channel blockers. There's two big ones here. There's verapamil and diltiazem. Now, if you had to put kind of a spectrum here, so we're just going to draw a heart here and we'll do a blood vessel here, okay. So verapamil is over here, okay. So verapamil is going to be mostly working on the heart. And again, I told you, what does calcium channel blockers do? Calcium channel blockers block L-type calcium channels. This guy right here. If you block this upstream mediator of this whole mechanism, then you're not going to get calcium in to induce more calcium to be released. So it has a greater effect on calcium-induced calcium release. That's why it doesn't really affect skeletal muscle. So in the heart, what's it going to do? Decrease contractility, right? Slow down the heart rate, bradycardia. That's what verapamil is going to do. Now, you might be saying, okay, what about diltiazem? Yeah, diltiazem can do that too. But diltiazem is more kind of in this range where it can actually affect the heart, but also have effects on the vascular smooth muscle. Now, it's still inhibiting the same channel. The pathway is very similar, but instead, that is going to cause vasodilation if we're affecting vascular smooth muscle. So with diltiazem, you'll get decreased contractility and some vasodilation. Dihydropyridine calcium channel blockers are going to be the drugs like nifedipine, amlodipine, nicardipine, right? So amlodipine is very long-acting, nifedipine is very short-acting, and so these are probably the two highest yield in the group here, and that's why one would be used over another. So nifedipine gets the blood pressure down right away, amlodipine kind of acts over a longer period of time. Now remember, when we're talking about this vasodilation, if it's venous, if I have venous dilation, that's increasing the capacitance of the veins so I can store more, right? The veins get bigger, I can store more. Veins are going to be storage, right? It's like your big refrigerator storing all the blood. Okay, so if I vasodilate the veins, I decrease the preload because I'm storing more blood. There's going to be less getting back to the right atrium. If I dilate the arteries, I decrease the afterload, decrease the TPR. Now, calcium channel blockers primarily work on the arterial side, which means they're primarily going to be used to decrease the afterload, decrease the blood pressure. And so the last thing I want to say is that these dihydropyridine calcium channel blockers, I'll put them here, dihydropyridine calcium channel blockers, they're going to be the farthest to the right here, primarily on the arterial side, little effect on the heart. And you might be saying, okay, Dr. Viso, but if I have dihydropyridine calcium channel blockers and they're dilating the artery, well, won't that cause tachycardia, like a reflex tachycardia from the drop in diastolic blood pressure? And I'd say you're absolutely right. That's a reflex, though. It's not a direct effect from the medication. Even though the heart rate goes up to give you a little bit of extra points in the cardiac output, the heart rate will never go up enough physiologically to compensate for the drop in blood pressure. We never overcompensate physiologically. Okay, so overall, if you give somebody a calcium channel blocker, my point is you would expect that there should be a decrease in the blood pressure. All right, phosphodiesterase 3 inhibitors. So there's two major phosphodiesterase inhibitors I want you to be familiar with. This is the first one. So phosphodiesterase 3 inhibitors, both of these, by the way, these phosphodiesterase inhibitors, they're going to inhibit the breakdown of a cyclic product. Okay, so the first one is phosphodiesterase 3, inhibits the breakdown of cyclic AMP. Now, we haven't talked about this a lot. We're going to talk about this when we talk about epinephrine, isoproterenol, and so forth. But CAMP in myocytes is associated with the GS pathway. Okay, and I'm not going to go into all of it here, but that GS pathway is stimulatory. So it can cause the myocytes to have stronger contraction. So This phosphodiesterase 3 inhibitors, if they work at the myocytes, that can cause increased contractility. They can also work in the vascular smooth muscle. They increase sarcoplasmic reticulum uptake. Remember this guy right here, CERCA, right? The CERCA pump pumps the calcium back in to cause relaxation. Okay, so this is where these phosphodiesterase 3 inhibitors would primarily be acting. Milrinone, for example, is a great drug for heart failure, systolic heart failure, because if I have systolic heart failure, my overall contractility is down. And so I can increase that contractility, right? I inhibit CAMP degradation, so I have more CAMP, which is essentially what epinephrine does, causes you to have more CAMP, higher contractions. That's what milrinone does. It increases the contractility. So in systolic heart failure, that's great. And on top of that, it's going to decrease my afterload, right? It's going to cause more calcium to get taken up into the sarcoplasmic reticulum so that in my intracellular space, I have less calcium. Less calcium is associated with relaxation. Because if I have less calcium, I have less calcium binding to calmodulin, which is less activation of myosin light chain kinase, which is less myosin light chain phosphate, which is less phosphorylated myosin light chain, less contraction, okay? Less vasoconstriction, more vasodilation. If you talk yourself through some of these mechanisms like 2 or 3 times, I promise it will start to click, okay? You just have to kind of talk yourself through it a little bit. All right, so primarily used for peripheral arterial disease. We'll talk about that in a little bit, but for a lot of the same reasons as we talked about, having the vasodilation, better perfusion. Now, dipyridamole is actually really interesting, so let me just do a quick tangent on this. So let's imagine, we have some blood coming in here, okay? And let's say we have 2 vessels, okay? And let's say that this vessel has some really bad atherosclerosis here, okay? So it narrows, but then it's okay. After that narrowing, it's okay. But then this vessel, it's patent, no problem. We're gonna pretend that these vessels are coronary vessels, supplying blood to the heart. Now, my blood comes in, and it's got a choice. It's just like if you go back to your physics with your circuits. You got a lot of resistance here, not quite as much over here. There's more dilation. So what happens is these distal vessels and some of this vessel, they will try to dilate. Okay, so these vessels will try to dilate and say, look, we're not getting as much blood. We need to get blood to these regions of the heart. So let's dilate. If we dilate maximally even, right, we can get just as much blood as this side. We can get a little bit more blood from this side so that this is more equal, as opposed to this open area of highway where there's blood just coming through. So this is the basis. If you understand this, you can understand what dipyridamole essentially is used for and what it does. So dipyridamole is going to be a vasodilator. Because it's a phosphodiesterase 3 inhibitor, it also causes increased levels of adenosine. And you might remember in the coronary vessels, adenosine is going to be contributing to vasodilation. Okay, and dipyridamole essentially does this by inhibiting the breakdown of adenosine. So there's more of it around. So more adenosine, more coronary vasodilation. These vessels on this side, they're maximally dilated. They're not going to dilate anymore when adenosine is around. But these guys over here, they can dilate. They're not dilating at baseline, right? So we can dilate them because they're not dilated yet. And so these vessels are going to get really big and steal a lot more blood. But these vessels can't get any bigger because they're already maximally dilated because they have this region of stenosis, right? And they were trying to compensate for that by maximally dilating. But I just gave a drug that causes everybody to dilate. So what happens is I'm stealing a lot of the blood that was going to this region. Okay, that's what dipyridamole does. That's why dipyridamole is used in cardiac stress tests, okay, as a pharmacologic agent for stress tests, because it stresses the heart, right? And people can't understand, well, how does dipyridamole, by vasodilating, stress the heart? It's because you already have regions of stenosis that are maximally dilated. So when you dilate the normal regions, those normal regions are going to steal all the blood from the regions that have stenosis, and that's going to cause symptoms, ischemia. That's why adenosine is also used for pharmacological stress tests. Now, the third drug that's used for pharmacological stress tests is dobutamine. And dobutamine is a little bit easier to understand. Dobutamine basically just causes increased cardiac contractility. That stresses the heart because you're increasing myocardial oxygen demand. But anyway, that's what dipyridamole essentially is doing, okay, because it's acting at these coronary vessels, increasing the levels of adenosine. Finally, the last couple things on here, we have nitric oxide, okay, which we've already talked about, primarily acts at the venous side. Remember, nitric oxide is going to cause increases in what? CGMP, right? CGMP is going to decrease intracellular calcium concentrations, by stimulating myosin light chain phosphatase, right? We talked about that, and myosin light chain phosphatase will dephosphorylate myosin light chain so that we get less contractions. Hydralazine and minoxidil are both going to act more on the arterial side. So while nitric oxide will be primarily decreasing preload, hydralazine and minoxidil will primarily be decreasing your afterload. Nitroprusside is going to be the one in the middle. You might be saying, okay, well, I have a venous dilator, I have an arterial dilator. Nitroprusside is going to be a little bit of both. Okay, so it's going to have some arterial effects and venous effects, so decreases in afterload and preload. Now, the last one on here is sildenafil, commonly known as Viagra. Okay, so sildenafil is a phosphodiesterase 5 inhibitor. So we talked about phosphodiesterase 3 being associated with CAMP. Phosphodiesterase 5 is associated with increased levels of cGMP. Okay, so it's going to inhibit the degradation of cGMP. So we already said what cGMP does, right? If I have increased levels of cGMP, I'm going to have more activation of myosin light chain phosphatase, more relaxation. Now, the thing about sildenafil, though, is it primarily works at two areas. Now, I already said that sildenafil is Viagra, right? So it'll dilate the vessels at the corpus cavernosum, right? And so it can cause erections in men. And then it also has effects on the pulmonary vasculature. So if you have a patient that has pulmonary hypertension, sildenafil or phosphodiesterase 5 inhibitors can be used to bring that pressure down. Two big points. First one, you don't want to give nitric oxide and sildenafil. You don't want to give venous dilators with sildenafil. That's contraindicated. You can make these patients get very hypotensive. In fact, you really don't want to give two of these together in general on this list because you can really drop the blood pressure. So that's the first thing. They're contraindicated when they're used together because they have similar effects on pressures. Okay, so that's number one. Number two, be careful with these in inferior wall MIs because those tend to get asked about as being preload dependent. And if you take someone's preload away, like you would with nitric oxide, for example, by dilating the veins, that can worsen inferior wall MI. So just keep that in mind.